You're tuning into the Active Mom Podcast with physical therapist Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right. So recently there was a paper that came out and also a presentation at a recent conference kind of coining the term genitourinary syndrome of lactation. And what so many of us that have been in the space for a long time, one, we're cheering. And two, a lot of people are like, wait, what are you talking about? So we decided to have one of the authors come on the show, Sara Perelmuter. She is a second-year med student at Cornell Wheel Medical Center, and she's going to come talk to us about kind of figuring out hormones and postpartum and lactation and all that fun stuff. So Sara, welcome to the Active Mom Postpartum Podcast.
Thank you so much. I'm so happy to be here. And so, yes, I'll just give a kind of overview. And so basically I'm part of a sexual medicine research team, and we were first looking at actually the term GSM, which is the genitourinary syndrome of menopause. And so that's looking at women who are going through menopause. And in menopause, we know that there is a decline in the level of estrogen and hormones. And basically that causes a whole host of symptoms, typically that we associate to menopause, things like insomnia or brain fog, but also in addition to those systemic, like whole body symptoms, you also get genital and urinary symptoms due to those decreased level of estrogen. But then we thought, wait a second. Menopause isn't the only time in somebody's life where you could have this decreased level of estrogen and androgens and different hormones. And we were seeing anecdotally that a lot of women and individuals postpartum who were also specifically lactating or breastfeeding their child, they also experienced this decreased level of estrogen. And we can get into the specific biology of that later on. But basically, there was no vocabulary to even talk about this or to even address this. And so really this project was to coin, as you mentioned, this new term, the genitourinary syndrome of lactation, which is basically describing individuals who are postpartum and lactating, how they also have a whole host of genital and urinary symptoms that we think are due to this decreased level of estrogen and androgens that occurs in this postpartum lactating state.
Yeah, it's funny. The more that we've now kind of opened the floodgates on the menopause and hormone conversation, I feel like I'm looking at postpartum in an entirely new way, which is kind of insane because we know like it's kind of normal. Yes, estrogen rises in pregnancy and it crashes and burns on the other side. But like, I think the question a lot of people have is we don't necessarily understand, and we weren't taught in middle school health class, what does estrogen mean in the context of these tissues? Why urinary symptoms? Why the genitalia? So what's the role of estrogen and down there, and kind of why is it important?
Yeah, exactly. That's a great question. And so estrogen has a couple roles all over the body, but also in our tissues. So for example, estrogen plays a significant role in basically maintaining healthy tissue. And so we talk about the skin epithelium, so the skin cells. And so estrogen maintains basically something called collagen, which is kind of keeps the skin nice and healthy and plump. And so basically, when you have a decreased level of estrogen, the skin tissue doesn't have that richness and that plumpness that it does anymore. And so basically the tissue itself, the skin, can actually atrophy. So it actually kind of degrade and become thin, less elastic. And so if you're touching it, it can be easier. It can rip easier. It can tear easier. You need more kind of lubrication or, care to when you're touching it. And so there's, on one level, just vaginal atrophy and vaginal dryness from a lack of estrogen, where normally the estrogen will help kind of maintain and turn over these skin cells. And also, a really interesting point is, specifically when we're talking about estrogen within the vagina, is that we also have something called the vaginal microbiome. And so we're starting to learn a lot about the microbiome, for example, even in the gut, and how important that microbiome and that environment is for our overall health. But in our vagina, we also have this microbiome. And so basically, the microbiome is full of thousands and thousands of different types of bacteria. But a lot of these bacteria are actually good bacteria, and they help maintain the pH, so the level of acidity in our vagina. And so basically, they can help protect our vagina against incoming pathogens, incoming negative bacteria. And so basically, they help maintain this healthy vaginal environment. But we know that estrogen is really key in maintaining this. And so why is that? So basically, estrogen gives it basically helps feed one of the prominent bacteria called lactobacilli. So lactobacilli are kind of the dominant good guys down there in our microbiome. And so sometimes if you do swabs, nowadays you can even buy kits that test your vaginal microbiome, which is really cool. So if you do those, you'll see you usually want a dominant lactobacilli, because lactobacilli, fight off all the incoming negative bacteria. And so estrogen, they basically help stimulate glucose, and they help stimulate feeding these lactobacilli. And so when you have a low level of estrogen, for example, postpartum lactating, in addition to all the skin atrophy and dryness, also the population, you're no longer able to feed and to maintain this population of lactobacilli. And so sometimes you'll get a dysregulated microbiome, or basically you'll have a imbalance of pH. So the lactobacilli, which is normally protecting your vaginal canal and maintaining the acidic environment, is no longer able to do that. And so you're more susceptible to things like urinary tract infections or yeast infections. And so it's not just the tissue itself, it's also the whole vaginal environment. And that can cause really significant distress as well.
Yeah, I was gonna say the last thing you need when you're a new mom lactating is to have any sort of infection whatsoever. Like that's definitely not what we're looking for. So, how did you, just kind of parallel wise, because I know if you're diving into sexual medicine, there's a whole other side of sexual medicine that kind of has looked at some of this stuff over the years, as far as like painful sex and things like that, aside from lactation. Can you go into that a little bit, and then kind of where you're starting to draw some parallels between like what we're running into in this low estrogen situation versus like somebody with vulvodynia or something along those lines?
Yeah, absolutely. So I just like to preface this by saying that, like, historically, there's been a large lack of research and interest and funding and innovation in women's health in general, but especially regarding women's reproductive health, especially regarding pain in the reproductive organs. Even calling like them the reproductive organs, it's kind of just like saying that their entire function is for reproduction.
Right.
So really all the research historically that's really been focused on is it related to fertility, or is it related to cancer? And if it's not, it's like,
forget it.
No one, no one cares.
Right.
Which is, extremely frustrating. So it's really been in the past, like 5 to 10 years, that there's been increasing attention towards chronic pelvic pain conditions, that, because a lot of them are actually, not super rare, like relatively common. We're talking about endometriosis. A brand new study came out of Australia that just said, we thought endometriosis, which is a debilitating chronic pelvic pain condition, specifically around painful menstruation, we used to thought it was 1 in 10 women. Now a new study just came and said it's 1 in 7 women.
I believe that.
And for that, for example, the diagnostic journey in the US, it's approximately 8 years to get diagnosed. which is
Oh, yeah.
absolutely ridiculous.
Yeah. No. I mean, like, with that one, like, I've been treating endo probably for 25 years, and the fact that we're even uttering it in the past couple of years, there's so many women that come in now, like, "Yeah, strong, painful periods." I'm like, "Yep, yep, yep." Like,
Yeah.
the fact that we're, like, finally acknowledging it, I'm like, "Thank you."
Yeah, exactly. And we're lucky, like, endo is getting more attention also in the press, but
Yep.
we also have other chronic pelvic pain conditions like vulvodynia, vestibulodynia that trained physicians have never even heard of. A lot of trained physicians, they can't even point out or say what the vestibule is, right? The vestibule is kind of the bridge between the vulva, which is the external genitalia, and the vagina, which is really the internal vaginal canal. And the vestibule is kind of this little like bridge in between those two areas, but physicians don't even know this vocabulary. And so it's kind of on the basis, like, how are we supposed to identify and treat all these things if it's not even integrated into our curriculum? And so I just want to preface really that question by saying, like, there has been, an entrenched dismissal of women's pain in the medical system, exacerbated when we're talking about pain in female reproductive spaces. But moving on, in the past couple of years, there has positively been more attention towards sexual dysfunction and chronic pelvic pain conditions, as we previously mentioned, but not specifically in the context of postpartum.
Yeah.
Usually, and I think there's been some kind of point that, like, oh, postpartum is just transient. It's not quote unquote like worth it, because it's like, your postpartum, the hormones are changing, this and that, but then you're going to go back to normal, whatever that means. And so kind of just this dismissal, disregarding the quality of life at an extremely vulnerable and intense period of your life. Which is extremely, dismissing and condescending almost. So that's where we kind of wanted to bridge the gap. So the majority of research, I would say, there's been lots in endometriosis, trying to find basically ways we can diagnose endometriosis that are easier and more accessible, rather than having to do a surgery where you go in and actually see the endometriotic lesions. And then there has been some research in basically dyspareunia. So dyspareunia is the word we use when we're talking about painful intercourse. And so things specifically, for example, surrounding menopause and dyspareunia and menopause, or even dyspareunia due to, other kind of like trauma, female genital mutilation, or like lacerations traumatically during birth, and basically kind of the output of that. And then there has been some research around, as I mentioned previously, vulvodynia and vestibulodynia, much less, but there is in the past couple years only. So for example, vestibulodynia, there was a recent paper. Basically, vestibulodynia is when you have usually some sort of trigger of inflammation or trauma. For example, even a yeast infection can trigger it. And so when you get trauma or inflammation to your vestibule, this area between your vulva and your vagina, you'll have these cells called mast cells that will come to that area, to the vestibule, and try to help fix the inflammation and try to help in recovery of that tissue. But what happens is that those mast cells, they get stuck there. They can't leave. And the mast cells, they also, in addition to help producing, inflammation, they also produce something called nerve growth factor. What does nerve growth factor do? Well, it helps grow nerves. And so basically what you get is an extra growth of nerves in the vestibule, but so much so that it's pathological, that you have too many nerve endings in your vestibule, so that it's become super, super sensitive and super painful. And so women with vestibulodynia, they can't even wear like tight underwear or thongs, or even ride bicycles, or let alone sexual activity, because they're super like sensitive in a painful way. Yeah. And so these conditions exist, and they can be very distressing and debilitating. But it was only recently, and I think it was in in like 2021 or something, that paper was published of the pathophysiology of these mast cells in vestibular dynia. So it's still very recent.
Yeah, no, I'm smiling inside because I know two of your mentors quite well, Dr. Jill Kraft and Dr. Rachel Rubin, and I'm smiling inside because you are so well versed as a second year med student on things that literally my entire career we've been like banging our head against the wall to have patients get decent care, and we're finally getting explanations. And I just love that you're like so matter of fact about it. As a second year med student, I have hope for our future.
Thank you. No, I mean, it's something that, because no one talks about it, and makes me, I'm passionate about it, but it's also it's exciting because I feel like as an up and coming student, it's almost like, oh, I can go into this space and make an impact. And that's also, motivating to me. But it's crazy because I have these amazing mentors, Dr. Rubin and Dr. Kraft, which you've mentioned. But even in like my basic med school curriculum, it's not like we're really focusing or so much inclusion on this as well. And so it's also to some extent like I'm seeking it out as well. And there's some programs, there's a great advocacy group called Tight-Lipped, and they're trying to integrate chronic pelvic pain treatment into OBGYN residencies, because sometimes it's not even like a standardized curriculum in them. And so it's really also part of this like foundational curriculum that we also need to address.
Yeah, no, I feel like your education is probably very similar to ours in that you kind of drink from the fire hose for a really short period of time to learn a little bit about a lot of things. And then eventually you find your specialty or whatever. But I do think like even if you stay a generalist, like it's important to understand these things to at least know where to point people. And I'm sure your curriculum is so like full anyway, and nobody wants to stuff in even more. Like, how did you figure out so early that this was something that you wanted to dive headfirst into right off the bat?
Yeah, that's a great question. And I think it was almost like it's like a perfect storm for me. It's like, how do we end up in anything that we're doing?
Yeah.
I think, it was a mix. So I knew, like through high school, I knew that I wanted to go into science and potentially medical school. But I didn't know like specifically what area within that. And then in my undergrad, I ended up doing, kind of also by fluke, I ended up doing my a research project and wrote my thesis on basically the sex differences in pain processing. And so basically how
just a small question.
I know how basically it was, how underlying molecularly, like on the cell level, females and males, biologically speaking, process pain using different cell types and different biological mechanisms, and how basically this was found out accidentally, of course. So, traditionally research only used male mice because it was thought that female mice were too variable due to the menstrual cycle.
Right.
And so at some point, the researchers wanted to increase their statistical power. And so you do that by increasing your sample size. And so they were like, okay, I guess we have to include some female mice in our study. And when they did that, they found that all their hypotheses about pain processing were confirmed in the male mice, but not confirmed in the female mice. And they said, wait a second. Anyway, so I kind of dove into this whole thing looking at sex differences in pain, and also kind of on the backdrop of how, this was an accident, an accidental discovery. And so that kind of got me interested in the academic side, because I'd heard of, things like inequality, pay gaps, and, misogyny in our society. But for me, I love science. And so to me, the fact that like this, sexual discrepancy like penetrated science and scientific research, that like hit home for me. And I was like,
I'm so sorry. I'm so sorry.
I know. And it's, it's gone downhill, all my, all the exposure. But that was the first moment where I thought, like, that's crazy. Like, I thought science was this, beacon of truth and of evidence. And then seeing all this bias and this massive gap, just like a big black hole in in women,
Well, you kind of
about women.
yeah, I mean, what's funny is like, and it's not funny, but like it's funny in that you're like, oh wow, science in inequity, and then you dive down like the biggest rabbit hole ever of like, oh, sexual health, and then at the very bottom of it is like sexual health and postpartum. It's like that's
Yeah.
the like I don't know that it goes much lower than that.
Yeah.
So I was like, wow, you went down that hole really fast.
Yeah, I know. It's crazy. You just like keep spiraling. And yeah, and then in addition to the academic kind of side of things, then I also, would be volunteering and shadowing, in clinics and seeing just, sometimes like you mentioned, it's like part of the education is we want to educate because it's like, a woman may go to her primary care physician, not even an OB-GYN with symptoms of menopause, for example, but the doctor may not know. There was like Oprah was saying, she went through multiple doctors and years of symptoms and like, oh, it was menopause. That's what it was. And no one knew, they were running all these
Right.
types of tests. And so also kind of seeing the like in clinic, like women who like didn't know what was going on, physicians who didn't know what was going on, kind of, both. Then I was just like, okay, I see it clinically, I see it, academically, like what's going on here.
Yeah.
And then also what it really inspired me is I also got during my master's, I was part of a femtech club. So femtech is basically startup entrepreneurs specifically aimed at women's health. And so you have things like startups creating new diagnostic strategies for endometriosis. There's a company creating also kind of like creating a pad that can analyze different biomarkers in your menstrual blood.
Oh, cool.
Instead of like doing a blood test. There's all sorts of just different innovative companies. There's one also that I think is so cool. It's like a smart vibrator that can actually measure your pelvic floor contractions. And so there's all these types of innovations. And so that was also, I thought, oh, wow, like, I guess there hasn't been these innovations before. And so just kind of a mix from all sides, academically, clinically, almost like business wise, and seeing like, okay, there's definitely a gap here. How can I kind of come in and address this gap? And as you said, okay, first level, just like women's health, then like sexual dysfunction. And then like we're going even more niche looking at postpartum lactation because truth is no one has, really addressed it or talked about it before. And there's other, like we're thinking about expanding this genitourinary syndrome and making it an umbrella term. And under it, you'll have branches, genitourinary syndrome of menopause, genitourinary syndrome of lactation, but also things like if you're taking hormones in terms of like transgender processes, or if you're like post medications for other reasons, and basically including different causes that you could be in this hormone deficiency, and kind of like looking big picture, like it's not just this isolated one-time event. There's different causes and different times in your life that you could have hormone fluctuations.
Yeah, no, I love that. And again, like the more that uttering the word estrogen has not been like a dirty term, and now that we're like, hey, we can talk about this now, it really has made me look in the rear view at that. And it seems like a simple answer. We've talked, we're talking regularly now about vaginal estrogen and how it can save your life and all that stuff. But there's a lot of barriers talking about vaginal estrogen in the context of, or like historical barriers in the context of talking about it with a lactating mom. And you kind of go into that a little bit in the paper. Can you kind of give us the highlights on that?
Yeah, for sure. So we know that I'll first just vaginal estrogen, then I'll go specifically into lactation just to give it some foundation. So we know vaginal estrogen topically, we're talking about vaginal estrogen in a topical form. So cream basically that you can topically place on your vulva and vagina. And there's also suppositories you can insert similar to a tampon. And so basically we know that, they are safe and they are life-saving. I've seen cases where women come in refusing, not necessarily refusing, but not, having significant atrophy and dryness, and then basically due to penetration having a tear and a fistula, such that they go into sepsis, they go into all body infection, and it can be fatal. And so basically, in our paper, we look at vaginal estrogen, and we look at mainly studies where vaginal estrogen has been used. So that's in mainly like menopausal women. And there's very few studies that have looked at it in pregnant women or postpartum women, because usually pregnant women are largely excluded from research trials as a way to, because they're a vulnerable population, as a way to protect them, which of course is important. But at the same time, we have no research on pregnant women. And so when pregnant women get sick, we don't know what drugs to use, or we don't know anything to use, because we don't know what's safer and what's not. So there's really a line there in general in all health that we have to walk. But specifically on the studies that looked at topical vaginal estrogen, when you use vaginal estrogen topically, so not systemically, topically, the levels of estrogen in the blood, they don't significantly rise due to that topical use. So basically, there isn't a significant change in the body of higher levels of estrogen when you're using it topically, because it just diffuses into the tissue locally and kind of feeds those epithelial cells, like we talked about before. And so it doesn't increase the serum level, the blood level of estrogen. And so if in the case of a postpartum lactating woman, of course, the main fear is that estrogen levels or whatever you're taking hormonally could transfer to the breast milk, and that would transfer to the babe. And of course, that is a really important concern that we have to look into. But these studies that have been done suggest that when topically used, the levels in the blood do not significantly rise. There's no change in them. We can't even detect that there's been estrogen in the blood. And so if the estrogen isn't significantly increased in the blood, there's no possible way that it can transfer to the breast milk, because it's just staying locally in the vulvar area that's been used.
Yeah. And I feel like that's one of the two areas where, like, we just wouldn't even bring it up, or doctors wouldn't bring it up with postpartum clients. Was one, everybody for a very long time before the WHI was debunked was, estrogen equates to breast cancer. That's a whole other episode, which we know is not true, and especially not in topical. But then moms were fearful that using estrogen would impact their breast milk supply. And for any of you that are listening that have breastfed before, you're not going to do anything that's going to stop the liquid gold. Like, you're just not. And so many women suffered needlessly because they were afraid, and they felt that they had to choose between discomfort in their vaginal area, in their vulvar area, urinary symptoms, all of these things. They had to choose either treating that or breastfeeding their baby. And like, you're always, especially new moms, you're always going to choose your baby every single time. And so that was essentially the choice that women were given for a long time. And now what we're saying is like, hey, I don't know that we necessarily have that as a choice to make. It may be not even a question, because it is so local.
Yeah, exactly. And it's like, there is definitely that the overshadow from the Women's Health Initiative study that's caused a lot of hesitations in people, but also physicians in prescribing vaginal estrogen. But there was one study I remember that we mentioned in our paper where it looked at lactating women using topical vaginal estrogen. I think there were also maybe suppositories. And they gave the vaginal estrogen in different concentrations. I think it went from like 50 to 100 milligrams in different groups. And they found that even in the highest vaginal estrogen group, they found that it wasn't detected in the serum. And nowadays, the estrogen that we use is even lower than those doses. And so really, like, there is this this history and this overshadowing of the fear, but it is safe and it is effective. And actually, my mentor, Ruben, you may have seen this, she actually was just at the FDA this past week petitioning them to take off this black box warning on vaginal estrogen on the box that you buy it with, because it causes a lot of hesitation and concern for physicians and for people taking it, and saying that is actually there's been kind of this fear mongering surrounding it, but it can actually be really significantly positive. And I also want to mention that in addition, not just some women, lactating women, are not only concerned just about the estrogen may transfer in the breast milk, but also I've heard concerns that for postpartum mothers is the impact of estrogen therapy on breast milk supply itself.
Right.
That you mentioned. And so again, numerous studies that we cited showed that there was no significant changes in the levels or the amounts of estrogen created. And like, as you said, it's, your body is ready, and it's basically your body is the primary stimulus is really the suckling from the baby and from the child. And so if they're latching, then you'll be making. And so really, with the lack of plasma, with the lack of blood, estrogen changes or increases, there can be no effect on breast milk transfer or breast milk supply. So really, just to reassure both women and physicians of being able to use this as a treatment.
Yeah. Now we do have more moms these days that are choosing not to breastfeed. And I'm curious, every mom after having a baby, that estrogen plummets, whether you decide to breastfeed or not. And that plummeting estrogen does kind of cue that prolactin and that whole process and that sort of thing. And I'm positive you're going to tell me there's no studies on this, because I'm sure that there's not. But any personal thoughts on, can you still have these symptoms that we're talking about, that we're coining, these genitourinary symptoms? Do you have to be lactating, or is it just postpartum in general that we're concerned about?
Yeah, that's a great question. And that's definitely something that we want to explore, basically also looking at postpartum in groups where, even if you're not lactating, when your period comes back, when you start menstruating again, because that can be a sign that you're ovulating, that your hormonal axis is again, working again, and isn't being suppressed by your pregnancy hormonal state. So what I think, again, we have to investigate it further, is that in postpartum, basically, like you said, your estrogen, your progesterone, basically it plummets, and you have this rise in prolactin, and that will basically suppress the hormone production of, basically what it does is prolactin inhibits the release of a hormone called gonadotropin releasing hormone, and that in turn causes secretion of luteinizing hormone and follicle stimulating hormone, which will then in turn cause production of estrogen and androgens. And so when you are lactating and you have continual prolactin increase and continual states of high prolactin, which stimulates the ongoing lactation, then you'll be suppressing that estrogen and androgen production throughout the entire time that you're breastfeeding. But if you're not lactating, postpartum, you still have that massive drop in estrogen and progesterone. So I think that initially you still have that that deficiency in estrogen and androgens, but if you're not stimulating lactation either via pump or breastfeeding, then theoretically those hormones would be able to essentially recover back to baseline faster, because they're not being continually inhibited by the prolactin. So I think you may have the initial genitourinary of lactation symptoms, but they won't persist. For example, for if you're breastfeeding for a year, you could have these symptoms for the entire time you're breastfeeding, versus if you're not breastfeeding at all, you may return and not experience as much or as significant of those symptoms. But something that we also want to investigate is, why do some women return back to menstruating 3 months after postpartum, and why do some women take a year to start menstruating again? And, the truth is we don't know.
Right.
Is it just individual variation? Is it, probably dependent if you're, lactating, because that will suppress, those hormones? Is it depend on the consistency or frequency that you're lactating? Is it, other, environmental exposures, stress? And so that's definitely something that I'm sure ties into it, that that's definitely an area of future research.
Well, that's such a funny one because there's so many like old wives' tales that gets handed down. And that's like one of the first PSAs that I give new moms is like, first of all, you can get pregnant while you're you're breastfeeding. Your cycle doesn't have to come back. Just know that. But like this whole idea of people think that because they're breastfeeding, that's automatically going to delay menstruation. And like it's just not true. My poor sister-in-law, 3 kids, every single one, her cycle came back at 6 weeks. And I was just like, that's just cruel. But there's so much variation, but that's not what we're taught. We're taught that, okay, your cycle won't come back until after you're done breastfeeding and you can't possibly get pregnant. No, none of those things are true, but we don't have any data to say how or why, or even people that are telling us that this is kind of normal. So yeah, I'm sure there's a lot of foundation stuff. That's why I hate about research is I'm like, okay, we've got to do the foundational stuff. And then finally you get to answer the questions that I want the answers to.
Yeah, no, there's so much, exactly. There's so much work to do, but it's like you have to do almost like stepwise to understand, what are we even talking about before we ask the questions. But it's true. It's like, why, why do some women have it at this time? Some women have it at that time. And like, does that impact their recovery postpartum, their ability to lactate? There's all these questions that can sprout from it. And and that's why, it's exciting, but it's also frustrating because we just don't have, the data to back up.
I mean, I'm guessing kind of where you are in life, but like how, like, is it surprising to you that we're sitting here in 2024 and like these questions have not been answered? Like, have you gotten past that kind of explosion in your face yet? And you've kind of moved on,
I mean, I just like, I think of it, I'm just always just like thinking like, this is so ridiculous. Like,
right?
what? Like, yeah, it is. It's absolutely insane. Like, we're in 2024. We have so much like advanced technology developments, all these things that are going on. And then, when it feels sometimes like in this one area, there's just like suddenly a scarcity. Suddenly, everyone's hands go up and it's like, and you think, okay, maybe it's just about, in this specific, like talking about research pain, a lot of people don't want to touch pain with a 10-foot pole because there's a mix of physiology, there's a mix of psychology. But then, hypocritically, if you're looking towards men's sexual research, if a male goes to his doctor and says, I can't, get an erection, it's like, bam, bam, boom. We have all of these medications, we have all of this, we have all of that. And so it's really not, science or pain research, in general. It is really in kind of this specific area. And, and it is, I mean, to me, it's like, there's no excuse. It's like, what are we doing? What have we been doing? Obviously not the right things, but a big part of it is also, what to do research is a lot of times you need funding for it. And it goes kind of back to a lot of, historically, especially a lot of the people, all of the people in powerful positions making the decisions of who's getting this funding, or, a lot of times old white men. That's historically how our society has run. And so there's kind of been this struggle that those individuals may not necessarily understand or believe or, empathize with female sexual dysfunction, especially postpartum, in kind of the struggles that and the issues that they cause. And it's not necessarily, it's like, it's all about, education. Like, I've had people that even, they hear about genitourinary syndrome of lactation and they question, like, is that even, they're like, are you sure? Like, is it that real? Like, is it real? Is it that significant?
I'm sure.
And so it's like, it's, we're battling to do the research, but to even do the research, it's a battle in itself.
Yeah, no, and the other thing too, and I'd like to bring up this historical point a lot this year, is getting more women in medicine. We're going to be saved by women in STEM, more women in research, and so that's part of the reason also that I wanted you on the show, because anything that I can do to leverage kind of and elevate your voice and get it like out there more, and so that someone hears you and is inspired by you to ask more questions, or somebody sees you and says, hey, this is what I want to do, or I want to be, the more, I mean, it's that whole kind of mentorship too. The more you see people that excite you and you want to kind of get excited with them, like that's how we're going to grow. Again, it's going to be women in STEM that fix all this and save the world.
That's so beautiful. I mean, that's amazing. It's so powerful when you're like, for example, there's a conference that we presented this at it's called ISHWISH, the International Society of Female Sexual Medicine, I think. And it's, being in a room, full of people that are also passionate about it, especially, women. It's so powerful and so inspiring. And so that, that does give me hope, but absolutely it makes me, so happy to, to hear your support. And that's also, what I try to do as part of the, as part of the sexual medicine research team, when someone reaches out, I have other medical students that sometimes are interested. I'm like, absolutely get on board. Like we need you, we need everyone we can get. And so just having that.
Yeah. And there's so many areas of this. I have a former client that it's in med school and navigating POTS. And she's like, we get nothing about POTS. I was like, I know, but you're going to change the world. I'm like, I just know it. I just know it. So, all right. So if you, like if somebody's listening right now, whether they are a provider, whether they are a mom, and they're like, okay, I don't know if this is me. First of all, what are the things that were like, okay, if you are experiencing this, or if you have a patient that's experiencing this, this is what you need to do next. And how can we recommend how to have that conversation and who to talk to kind of, get this addressed. So let's start with the first part. Like, what are the flags where you're like, yep, that sounds like genitourinary symptoms of lactation?
Yeah, great. So basically, as you said, the first step would be to maybe think about, identifying it in yourself. And so basically there's a couple, key symptoms we say. So one is talking about vaginal atrophy and vaginal dryness. So basically that's when you lose the estrogen there. So you may have a loss of lubrication, not just with sexual arousal, that as well, but also just a dryness kind of like every day, and may cause discomfort. You may feel it even just walking. You can kind of sometimes even before UTI, you kind of feel this kind of like airiness or burning. So sometimes you can feel just a natural dryness. Then you can also have pain with touching or insertion. So that can be pain with touching with fingers, with tampon insertion, with any insertion, with sexual insertion, with penis, with anything like that. So we call that dyspareunia, pain with intercourse, because that dryness and atrophy a lot of times leads to this friction. And then we also have urinary symptoms, which we briefly mentioned, but that's also things like changes in urinary urgency or frequency. So feeling like the urge to go all the time, or, needing to go more very frequently. And then also you can have things like urinary incontinence. So when you leak a little bit of urine, and then also, urinary tract infections. And then also, one thing we didn't mention that I forgot about estrogen's role in the tissues is because it's so important in maintaining the health of these tissues. In labor, a lot of the times there can be tissue damage. There can be tears, there can be rips due to the physical labor and birth. And so estrogen usually will promote this tissue repair and tissue healing by being, by plumping up these tissues. But when you have a lack of estrogen, what you may see is basically a delayed tissue healing. And that's, again, one of the last things you need when you've already gone through potentially, a physically traumatic birth. You want to recover, as your body is able to. And so you may see delayed healing of perineal tears or other wounds that have occurred during childbirth. So kind of those key things, I would say. And then what you can do is, first step, I would say, would be go to your gynecologist that's followed you or your obstetrician, that's followed you throughout your pregnancy. The truth is that this is a new term, and so not everybody is aware of it, including physicians. And so what can be really helpful is if you go to your doctor and you say, okay, I'm experiencing this, this, and this, and I'm experiencing it like this is not normal for me. You say, this is causing me significant distress, or this is, usually I go to the bathroom, X amount of times, but now I'm noticing that it's elevated. This is not my normal level. So kind of indicating that this is a new onset of symptoms. So basically going to your doctor with a list of what you are experiencing, and also the timeline to kind of illustrate, did this happen? Was it happening during your pregnancy? Was it or was it happening after? There can be other issues as well. And so you want to delineate, is this a postpartum occurrence? So we're talking about the symptoms, we're talking about the chronology, and then also if, because of the lack of awareness, which is, in general, you can also, say, or point them to resources. For example, point them, you can print out a publication, you can, print out other, research, kind of like evidence-based studies of, for example, the vaginal estrogen in postpartum lactating women studies, and say, and show them these studies, or send them those studies, because they likely will not have read them or heard of them or seen them. And so, coming prepared, rather than, doing a search on WebMD and being, I think I have this, or I think I have that, being more grounded in, what are your symptoms, what are the chronology of it, and what are like the evidence-based publications that kind of back up what you're experiencing, or what you want to look for.
Yeah, no, I think those are great recommendations. And, as we are getting more providers getting used to kind of a regular referral to pelvic floor PT, this has been a huge advocacy area for us, because lots of times if somebody has urinary symptoms and they are referred, they'll be referred to PT before even considering vaginal estrogen, which is funny because usually we're last. So this time we're not last. But anyway, for us to be able to delineate with someone's symptomology is like, how much of this is muscular and how much of this may be hormonal, and having the conversation, are you having vaginal dryness? Are you having painful sex? And to me, it always comes across a little bit more superficial as opposed to deeper muscular sorts of pain. And for me also, I have a pretty significant background in treating chronic pelvic pain. And so there's a lot of carryover there, but even just asking the question, and lots of times we have really strong relationships with the providers. And if a patient is like, hey, I don't know if they're going to be open to that, us kind of initiating that conversation, because it's a lot on a new mom to be like, let me educate my physician. And it's totally geographical. I'm sure you've kind of seen this too. Like I'm in the DC metro area. Obviously we've got good providers here. I'm finding less and less that I'm having to educate physicians, but there's a lot of places in this country and in the world where they're like, no, we're not going to do that. And sometimes if the education isn't going to be accepted, it's hard to find another provider that's open to it. So any way that we as pelvic floor physical therapists can help advocate and kind of open that door for moms, I think can be incredibly helpful. So it kind of becomes that team approach. But yeah, there's some work and education to be done for sure. This is not, just like you said, like, this is new. We need to take the time and take the effort to make sure that this becomes more standard of practice. And coining this term, I think it's very clear what you're saying by it, and just get doctors more used to, oh yeah, that's the thing. Cool.
Yeah, exactly. No, you're so right. Like pelvic floor, I think like everyone, as soon as you get pregnant, when you're pregnant, before you give birth, after, like, it should also be standard of care. But exactly, having you guys on our team, having, midwives, doulas, the whole, the whole team, everyone, aware of it, and making it just more normalized. And like you said, sometimes bringing it up, because there is still some stigma and some taboo around, sexual function, dryness down there, things like that. And so sometimes, asking the question, sometimes they'll just, start telling you, all these things that they're experiencing, and they're feeling. So it's also, sometimes it can be important to bring that up. So we're just trying to work on creating more awareness, more education, and doing more of the research that we can really get a better understanding of how to how to deal with all of these things.
Yeah, I love that. I love that. And again, like big picture is we've got to stop normalizing moms navigating all of these symptoms and just having to suffer through these symptoms that, oh, that's just part of being a postpartum mom. Lord knows we got enough to deal with. We don't, why don't we do an easy fix on these things that are easy fixes so that mom can spend her time and her effort and her mom guilt on something else.
Yeah, exactly. Like there are solutions that exist out there. Yeah. And so, it's like sometimes, you have to sometimes if a provider right away, there's a terrible, phenomenon of gaslighting, especially in chronic pelvic pain. And it doesn't mean that it doesn't exist, of course. Right. And so sometimes you have to fight for yourself. And I'm hoping that we'll kind of set this new term out with kind of this evidence behind it, and so that we hopefully just bypass this gaslighting scenario.
Love it.
But yeah, so that's what we're working towards.
I love that. I love that. Well, I, for one, am incredibly excited. One, again, that someone so early in their medical career is like, yeah, this is totally a thing. Let's burn this place down. I'm like, thank you. So thank you for being interested. Thank you for being inspired. Thank your mentors. Again, the ones that I know and love, and the ones that I don't know and love, or will love you anyway. But this is why I have hope, because there's just so much interest, and it's a lot to bring attention to some of these things. Coining a term, saying I'm going to do the research and try and get the questions answered, and it's a lot to do that. And as one, again, that I've been in this field for a really long time. Thank you from the bottom of my heart as a professional, and for everybody who's going to benefit from all of your efforts. It is not in vain. Let's burn this place down. Like,
yeah, let's do it. Let's like smash all the ceilings, all the glass ceilings, all the staircases, everything. It's like,
yes,
we want to change, this whatever this norm is.
Yeah.
So I thank you so much for inviting me on. I feel so honored and excited, and I just want to scream everything GSL from the rooftops.
Exactly. You need merch now. You need
yeah. Oh my gosh, we do. That'd be hilarious.
Get Rachel on that in all her free time, right? So,
yeah.
Awesome. All right. If you want to know more about Sarah's work, she'll try and post when she can, but girls in medical school and doing some research. So you can follow her on Instagram, Sara.Perelmuter. Thank you so much for joining me. Thank you for all the work that you do. And we're really excited to kind of see what comes up in your future. Thanks for being on.
Thank you so much.
Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Are you a postpartum mom or postpartum pro wanting to know more about getting back to running after baby? Check out all my free goodies on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.